change in the program to accommodate some flights that are going to be, that need to be caught, or else we'll have some problems. So the dislocated IOL and the AMSR grid debates are going to be moved up to follow the suprachoroidal injection debate. And otherwise, we're going to be keeping things the same, except that one of the participants, who was my original co-chair, is not here, Andre Romano. And ChaitraJayadev is going to be taking Andre's place. So Mike Stewart is going to be joining me as a co-chair. But in the meantime, we'll start, and the first presentation is going to be given by ChaitraJayadev, entitled What, How, and Why in Management of Wet AMD with Afilbercept. If you could bring up the slides, please.
At the outset, I'd like to thank Dr. Vishali for having included me in this excellent scientific program. I will be talking a little bit of Afilbercept for wet AMD. I think we all like to use the drug a lot, but I think the major constraint is the cost, at least in India, because a couple of talks that I've heard from speakers from the West use it more often than we do, because I think their health policies allows almost all patients to get the benefit of the drug. I have no financial disclosures. So what is Afilbercept? So we have several anti-VEGF drugs available right now for treatment, and we're seeing extremely good response to almost all the drugs. But I think a major concern remains because of the repeated injections that these patients need. One is the safety profile, second is the cost, and finally the dreaded endophthalmitis. So we want an option wherein the number of injections can be reduced to give better treatment outcomes for these patients. So Afilbercept is a recombinant soluble decoy receptor fusion protein. In contrast to antibody-based VEGF binding strategies used by other drugs, Afilbercept incorporates the second binding domain of the VEGF receptor 1 and the third domain of the VEGF receptor 2. So it comprises portions of human VEGF receptor 1 and 2 extracellular domains, and it's fused to the FC portion of the human IgG. So this is how it works, and because it binds it from both sides, it prevents interactions with other molecules. So like I said, it binds or traps both sides of the VEGF dimer 1 and 2, and it has a multi-targeted mechanism of action. And importantly, it has a very high binding, affinity binding to VEGF and PGF. So it binds it at a much higher affinity than the native receptors itself. It binds compared to other agents also much better, as seen in this analysis. And also it binds to PGF, unlike the other available agents. So one important thing is that it blocks the VEGF-induced activation of VEGF receptors along with a greater affinity, and blocks PGF-induced activation of the VEGF receptors as well. So the potency is almost 71 to 92 times higher. So this is as far as the duration of action goes, because of the binding as well. You see that the suppression lasts for almost 71 days in comparison to 36 days in this comparative study. Also, by mathematical modeling, it has been shown that it can extend with 2 milligrams to up to 83 days. So now, why Afilbercept, and how do we actually use the drug? So Afilbercept, because there is enough and more evidence now, we have clinical trials and we have real world evidence as well. And before I actually go on to these studies, some of the new terminologies that are now being used, at least in these studies, is proactive and reactive dosing. So by proactive dosing, they actually mean fixed dosing or treat and extend, where you're actually doing something even before you see a full-blown disease, as against reactive dosing, wherein you see the disease, you see the patient, you see a drop in vision. So that's either irregular or PRN dosing. So most of the studies, at least with Afilbercept, have been with proactive dosing. So to cover some of the clinical trials, there's been VIEW 1 and 2. Importance of this was that they were all treatment naive patients, And the difference between view 1 and 2 is just the geographical area where it was conducted, and they were divided into 4 random groups and given different schedules, as I have mentioned here. The primary endpoint was basically percentage of patients who maintained their visual acuity, which means loss or equal to 15 letters on the ETDRS at 52 weeks. But the results here of both year 1 and year 2 show in both view 1 and view 2 that almost 92 to 95% of patients did maintain their visual acuity at the end of even year 2. So what were the BCVA gains that were seen at 52 weeks were maintained up till 96 weeks, and 48% of these patients who had received at every 8 weeks maintained their visual acuity in year 2 as well, with the difference between the 2 injections almost extending up to 12 weeks. So here on an average, the vision only decreased by 1 to 2 letters. Excuse me. So this was the extension of the view 1 at 2 and 2. Here also you see that the visual gains are being maintained. So sorry. So going on to the planet as well, you can see that this was the protocol of the planet study, and you can see this was a rescue criteria. Since we already know about these details, at week 52 as well, the patients in both study arms gained 10 letters from the baseline, whether they had rescue PDT or monotherapy. The visual gains were quite similar, 10.7 and 10.8. And over 85% of them had no requirement for rescue treatment at year 1. So the key outcomes here were that the 52-week study showed that monotherapy is non-inferior to combination or using rescue PDT, and a vast majority of them didn't actually need it. At week 52 with monotherapy, more than 80% of the patients had no active polyps, and more than a third of the patients showed complete polyp regression. So this is how the 2-year data now pans out, which is come out recently. Here again we see that the visual acuity has well maintained even up till week 96. So this is one study that I'd like to talk about. This is the ALTER study. This is the Japanese treat and extend study of Afilbercept in neovascular AMD. This was a multi-center across 40 clinical sites, and 2 different approaches of the treat and extend was studied here. Important here is that there has been no direct comparison of treat and extend regimes till now, and this was the largest prospective study. So this is how they divided it. Patients were given at week 4, 8 and 16, and then at week 16 they were randomized into 2 groups, wherein the extension interval was 2 weeks in one group and 4 weeks in the other, with the primary endpoint being at 52, and then the study ended at 96 weeks. So here the major criteria for extension or reduction of the treatment interval was fluid, whether there was no fluid, residual fluid or new fluid. So here you see patients achieved good visual outcomes, gaining a mean of 8.4 to 9 letters, and the visual gains were achieved at the first 16 weeks itself, a lot of it, and then it was maintained. And what we saw here at week 52 was that there was an extension of at least 12 weeks between injection periods with good maintenance of vision. Even at PCV, the similar thing was seen. And what was achieved at year 1 was maintained up to week 96 with continued proactive treat and extend regime. So this is how they gained more than 15 ETDRS letters from baseline and maintained up till 96 weeks. And around half of them needed lesser injections than it was seen in year 1 at year 2. And what we saw here at 96, which was recently presented at the at the Uretina meeting, was that at 96 weeks they saw an extension of 16 weeks between treatment. So these were the key outcomes. There were considerable visual gains, and it was maintained at 96 in both groups, and they reached treatment intervals of at least 12 weeks and beyond. So these are some of the other treat and extend studies that have happened. One of them is the ATLAS study. This was the Afilbercept treat and extend study for less frequent administration of the drug. Here again, they had good outcomes, and 75% of the patients in this study had a treatment interval of at least 8 or more weeks, while 38% of them had 12 or more weeks between each injection. So the safety profile in AMD with Afilbercept has been quite good, with very low incidence of any major complications. And we see similar things is also seen in the real world studies. In treatment naive patients, this is an analysis of studies which had at least 50 patients included in them, and all treatment naive. You see good outcomes in these patients, and this is a comparison with real world studies. Here again, the gray columns are clinical trials, and they compare quite well with the real world evidence. These are the different studies. The first one is the VIEW study, the gray one, and the rest of them are all comparable. These are all smaller studies conducted across the world, and we're seeing good response. And these have been the two major studies, Rainbow and Pursue studies. These are again real world evidence which compare quite well with the clinical trials. But what they all actually conclude is that proactive dosing is much better than irregular or PRN dosing. So just one last example here, a 50-year-old female presented with submacular hemorrhage. So these are the angiography pictures. You see the PED with subretinal fluid and the hemorrhage here. So this is post first injection. You're seeing it's already resolving, and this is post the second injection. And this is the resolution that you see on multicolor as well. So to conclude, I think both the real world evidence and clinical trials do point towards a proactive dosing, and it does show that visual acuity is maintained, or we don't have a progressive loss of visual acuity once we treat these patients on a regular basis. Thank you so much.
Thanks. For time reasons, we'll have to move on. The next presentation is going to be given by Chabblani, entitled Marathon 6000.
Right, so good morning everybody. I'll be talking about the safety and efficacy of 5,768 DEX implants. These are my financial disclosures. The aim of this study was to evaluate the safety and efficacy of DEX implant in real life scenario. This was a multicentric retrospective study. We collected demographic data as well as comprehensive ophthalmic examination data. The inclusion criteria was that we need to have a minimum 6 months of follow-up after their last DEX implant, and we included various indications, that is diabetic macular edema, venous occlusion, non-infectious uveitis, and etc. These were the primary outcome measures. Safety of DEX implant was evaluated at 6 months with looking at the IOP rise as well as cataract progression. The secondary outcome measures was change in best corrected visual acuity at final visit, along with predictors for the final visual acuity. These were the various study sites across the world. 24 sites were selected, and we got the DEX implant data from each of these sites in a very uniform manner. These were the primary methods where we got 5,768 DEX implants, and out of that 2,735 implants were injected for diabetic macular edema, and I'll be focusing today only on the DME indications in this study. And these were the various parameters which we collected from the DME data, and we applied univariate and multivariate analysis. What were the baseline characteristics? We included almost 1,300 eyes of 1,300 patients with the mean age of 65 years. Males were predominant compared to females. And as you can see that we had more phakic patients compared to the pseudophakic patients. However, almost 1/4 of our patients had some form of cataract when we injected DEX implant. Let's move on quickly to the treatment outcome. If you look at the mean follow-up, it is more than 16 months of follow-up with the mean change in visual acuity, which was not significant. However, I'll be coming to that in more details in subsequent slides. But you can see that almost 43% of our patients gained some vision. 17% eyes did not have any vision improvement. However, almost 40% of these eyes had vision loss, but 20% of these eyes had cataract. Half of these eyes had cataract progression. Let's look at the phakic and pseudophakic arm. And as you can see here that there was not much change in the visual acuity in eyes which were phakic at baseline because of the cataract progression. However, pseudophakic eyes had minimal statistically significant improvement in the visual acuity. What about the comparison in terms of improvement in the vision? As you can see that phakic as well as pseudophakic eyes, almost more than 20% of these eyes had more than 3 lines of improvement, and almost 15% of these eyes maintained their visual acuity, but very few eyes, less than 10% or so, had visual acuity loss of more than 3 lines. What about the naive and previously treated eyes? And the more interesting thing which we experience in our clinical practice as well, that if you are injecting DEX implant in eyes which are naive for diabetic macular edema, they showed a statistically significant visual improvement, and as expected, eyes which are already recalcitrant, they are not responded to previous treatment, they do not do well, at least in terms of visual acuity improvement. Looking at the naive and the previously treated eyes, as you can see that more than 1/3 of the, more than 3 lines of the improvement was noted in more than 1/3 of these previously treated eyes, but most of these eyes had a very good maintained visual acuity. Looking at the univariate regression, we found that the baseline visual acuity, previously treated eyes, and the total number of injections were the predictors for the final visual acuity. However, when we put this data into multivariate regression, we found only the baseline visual acuity was significant. This is just a summary of what I just said. The baseline visual acuity holds the most important predictor for the final visual acuity outcome. What about the safety profile? As we discussed about the cataract progression, as you can see here that 14% of these eyes underwent cataract surgery during the follow-up, and almost similar percentage of eyes had cataract progression, but they did not require cataract surgery. What about the IOP rise, which is always a concern in these eyes, where we can see that 72 of our eyes already had a glaucoma, and they still underwent Ozurdex implant because the IOP was very well controlled by using the drugs. And you can see that 20% of these eyes developed ocular hypertension, and almost more than 90% of the eyes which developed ocular hypertension were easily controlled just by topical medications. But I would like to take your attention on this number, where you can see that the overall 0.004% of the eyes only required any drainage surgery. That proves that this drug is very safe. What were the limitations of our study? It was a retrospective study. Being a retrospective study and multicentric cohort, the follow-up protocol was obviously not uniform. The treatment and retreatment decisions were as per the physician, and we really could not evaluate at different time points. That's why we had to take the last follow-up in the analysis. However, this is the largest number of DEX implant in DME so far, which proves its safety in this cohort. And we saw pseudophakic eyes had significant visual acuity improvement, as we have experienced in the previously randomized clinical trials as well. And when you are using DEX implant, both the groups, naive as well as recalcitrant group, does show improvement of the visual acuity. But as we understand that the recalcitrant eyes may not have a significant visual acuity improvement, and this drug appears to be very safe in terms of IOP rise, where we can manage the IOP rise in more than 90% of these patients just by topical drops, and only 0.004% of these eyes required any filtration surgery. Thank you very much for your attention.
Okay. Well, thank you very much, Dr. Chabblani. In the interest of time, we'll move forward. That was a wonderful synopsis of an enormous series of Ozurdex injections. For the balance of this session, we're going to move into the debate format. And so the beginning of the debate is going to be, first of all, does everybody have a voting apparatus, the little clicker? Because we'll use that at the conclusion of each debate after both of our pro and con presenters have made their cases, a short synopsis, and then we'll go ahead and vote. So we're going to start with, the first question is suprachoroidal hemorrhages. And taking the pro position. Injection, what did I say? Thank you. Okay, thank you. Injections. Yeah, really. You want to inject hemorrhages? So we're going to start with suprachoroidal injections. And taking the pro position is on the right, Dr. Glenn Jaffe from Duke University. And I also asked Dr. SwapnilParchand to come up to take the podium to my left. so that he can immediately start after Dr. Jaffe's argument is completed.
If you can bring up the slides, please. On the right. Well, I'm very happy to be able to show you why a suprachoroidal injection is an excellent approach to drug delivery. By way of disclosure, I have consulted for Clearside. So what if I told you that you could provide extended drug delivery, minimally invasive injection, and deliver drug directly to the pathology site, providing a very highly effective treatment, while at the same time avoiding side effects of currently available drug delivery methods? Would you use it? Of course you would. Does that sound too good to be true? That actually describes a suprachoroidal injection, and it's real. My opponent might say, show me the data. Well, let's take the example of uveitic macular edema. And this was the POINT study, which compared periocular injection to sustained-release dexamethasone to intravitreal triesence. And you will see that there was about a 10-letter improvement in the eyes given the intravitreal injections, but it came at a cost. About a third of these patients required intraocular pressure-lowering medications during the first 24 weeks to achieve the visual acuity improvement, and we can do better than that. A suprachoroidal injection gives access to the back of the eye, and if you compare the delivery methods, an intravitreal injection with a 50 microliter bolus diffuses not just to the posterior segment, but it also diffuses to the anterior chamber in the lens. A periocular injection given as a half to 1 mil injection produces highly variable drug diffusion across the sclera and into the eye, which may account for the lesser efficacy I just showed you. And in comparison, when you give a suprachoroidal injection, the fluid flows instantaneously and posteriorly. It's designed to give consistent suprachoroidal injection through a consistent intraocular injection procedure, and the fluid with the drug is absorbed into the choroid, the RPE, and the retina. And if you look at the imaging and histology, you'll see that the fluorescent particles are localized in the posterior segment, and you also see this histologically with the triamcinolone particles in the choroid. But my opponent might say, what about the side effects? We just heard about side effects from intravitreal injections. Well, you get similar systemic triamcinolone exposure with the suprachoroidal when you compare it to an intravitreal injection. But you get greater posterior tissue levels with a suprachoroidal injection. And here you see the posterior segment tissue levels when compared to the intravitreal injection. But at the same time, you get less anterior segment exposure. And we don't want anterior segment exposure. And you see that the anterior segment exposure is negligible with the suprachoroidal injection, whereas you do get significant levels with intravitreal injection. And so my opponent might say, well, that's just a rabbit model. So what? Well, it actually works in people. So I'm going to show you some data from the Peachtree trial, which is a trial comparing suprachoroidal delivery to a control. And if you look at the efficacy, the primary efficacy endpoint was a greater or equal to 15-letter improvement in visual acuity from baseline. And you'll see that 47% approximately met that endpoint in the drug-treated group, the suprachoroidal injection, whereas only 16% in the control group did. And this was quite statistically significant and met the endpoint. If you look at the mean change in baseline visual acuity to follow-up through week 24, you see that there was actually a 14-letter improvement on average when compared to a 3-letter improvement. And this 14-letter improvement was better than what I showed you in the POINT study. For resolution of macular edema, and that was obviously an important point in the study, was to improve macular edema. Up to 60% of these eyes had resolution of macular edema as defined by a thickness less than 300 microns. And at the same time, you see only 14% in the control group. If you look at the mean change in central subfield thickness, you see it dropped rapidly and then was maintained out through week 24. Inflammation signs were decreased, and this included resolution of anterior chamber flare when flare was present. You see 74% resolution compared to 20% resolution. 68% resolution in vitreous haze, in eyes that had vitreous haze at baseline compared to only 23%. If you look at the safety, when drops were given for elevated intraocular pressure, only 10% compared to actually a higher amount in the control. And think back to the POINT study, that's a third less rise in intraocular pressure compared to the other methods of intravitreal injection. So to summarize those Peachtree data, the primary endpoint was met, There was improved visual acuity and macular edema. The inflammation signs were resolved. There were no serious adverse events attributed to the injection, with low rates of increased intraocular pressure and cataract. This is better than intravitreal injections, as I have just highlighted. So what's the take-home message from this presentation? I think suprachoroidal injection is a superb delivery method. It's not even up for debate.
Thank you, Dr. Jaffe. So giving the con on suprachoroidal injections is Dr. SwapnilParchand.
Good morning, everybody. So before we inject anything, any drug in suprachoroidal space, we need to answer some basic questions. First is that whether it is easy to deliver this in suprachoroidal space. Is there, after injection, is the availability better at target site? Third question is there sustained improvement with fewer injections? What is the benefit to risk ratio, and is there any rapid visual gain? So first we'll try to see how to access the suprachoroidal space. First is to cannulate the suprachoroidal space. But when we are cannulating, it needs little bit expertise. Then we can damage the posterior short ciliary vessels, which can lead to choroidal hemorrhage. And then there can be damage to photoreceptor layers. So other option is with injector, which is marketed by Clearsight. So this has tip of around 750 microns. But problem is that it is a blind procedure. We don't know whether we are in suprachoroidal space because the thickness of sclera varies according to the individuals. And then there is chance of reflux also. So then this is a tricky way to access the suprachoroidal space. Then we move on to the kinetics of drug delivery to suprachoroidal space. So when we inject in suprachoroidal space, is there uniform flow of particle in suprachoroidal space? No, it is not, because there are some anatomical barriers. So in this one of study, they have found that human short posterior ciliary artery acts as the anatomical barrier to particle spread within the suprachoroidal space. Therefore, design of drug delivery protocols targeting the suprachoroidal space need to account for barriers formed by the anatomical structures in order for the inject to reach a target tissue. Then how much volume we need to inject in suprachoroidal space? So in this rabbit model, they have injected ICG in varying volume, that is 50 microliters, 100 microliters, and 150 microliters. This hardly resulted into choroidal hemorrhage. But when they injected 150 microliters of triamcinolone, all 6 eyes developed suprachoroidal hemorrhage. And they noticed that with 150 microliters of injection, all had significant IOP spike. And because of this IOPic spike, they developed choroidal hemorrhage. The difference of IOP elevation between the two agents was due to the poor expansion and distribution of triamcinolone suspension in suprachoroidal space. Then there was head-to-head comparison between the intraocular injection and suprachoroidal injection in porcine model of bevacizumab. The author compared the pharmacokinetics tissue response between the intravitreal and suprachoroidal injection using bevacizumab. What they found that the level of bevacizumab attained in the retina was high at 12 hours, which again increased in the amount at around 7 days, and then there was steady decline, and it was maintained up till 90 days. But when you give the drug with through suprachoroidal delivery system, it attained peak at around 12 hours, and then there is sudden drop at around 7 days. Similarly, when they analyzed the level achieved in RP and choroid, they both attained similar peak at 12 hours, but then with intravitreal route, it again increased in the level at around 7 days, and then there was steady decline, which was maintained up till 60 days. But it was not case with suprachoroidal injection. There was sudden drop at 7 days. So the inference is that with suprachoroidal injection, it reaches the peak, but then there is rapid clearance because of high blood flow level. Then they also studied what are the vitreous level. Definitely it was more with intravitreal injections. So they concluded that direct intravitreal injection of bevacizumab has more sustained pharmacological profile than thus a similar dose delivered to a suprachoroidal space. Intravitreal injections distributed more to the inner retina, whereas suprachoroidal delivery occurred primarily at choroid, RP, and photoreceptor outer segment level. Then this is another study which studied the sodium fluorescein level. It has similar conclusion. Then in another study, they studied the molecular weight with suprachoroidal space. So they injected a dextran of different molecular weight in suprachoroidal space, and they noticed that the dextran of 40 Dalton showed a significantly lower retinal and vitreous level as compared to 4 Dalton dextran. They also studied the lipophilicity in suprachoroidal space, and they found that total drug delivery to choroid, RP, and retina increased with increased solute lipophilicity, whereas the vitreal delivery decreased with increase in lipophilicity. So they found that, they concluded that reduced vitreal delivery for lipophilic molecule is possibly due to retention of lipophilic molecule in choroid, RP, and retina, and low partitioning into vitreous. Then there was Tanzanite study which showed that the amount of injection is significantly less when you inject intravitreal aflibercept and suprachoroidal triamcinolone. Similarly, there was significant improvement in the visual acuity, and the thickness, central macular thickness significantly decreased with combination arm. But then there are few concerns, that is, it has small sample size, the duration of study was 3 months, the comparative arms were not equal. In one group they have just injected intravitreal aflibercept, whereas in other group they have injected aflibercept with suprachoroidal triamcinolone. And they did not mention about the possible retreatment of suprachoroidal injection of triamcinolone. Another important thing was, in only aflibercept group had lot more of patient with CRVO as compared to combination group. In Tanzanite study, mostly they found that the side effect which they found was IOP spike, but potential side effects which have been reported in other articles are choroidal hemorrhage, ocular hypertension, pain, damage to photoreceptor, iatrogenic retinal break, retinal hemorrhages, and anterior segment inflammation. So to conclude, suprachoroidal space offer a new attractive route of drug delivery, but there are few challenges that remains. First is ensuring sustained release of drug to overcome clearance by choroidal flow. Second is current formulation that is being used for intravitreal route need modification for suprachoroidal route. Then we should have consistent, control, accurate, reliable, and easy drug delivery system for suprachoroidal delivery of drug. We should have minimum drug toxicity to surrounding tissue. Then there should be decreased systemic absorption and ocular side effect. And lastly, we need more data with long follow-up so that we can have better approach. Thank you for your patient hearing.
Thank you. So to summarize, Dr. Jaffe on the pro side has shown us very compelling data with uveitis and uveitic macular edema, and also highlighted the safety of the drug when used in that condition. Dr. Parchand has highlighted some of the inconsistencies with the pharmacokinetics that have been shown in some of the animal models, and then has highlighted some of the concerns in the Tanzanite study for the retinal vein occlusion. So that being said, both of the presenters, I think, agree that this is in development. This is a very promising technology in development, not yet through phase 3 trials, and so that's why it's a subject of debate, is because we don't have the final answer just yet. However, the onus now falls on you to tell us, is this technology worth it? And if it were available today, for example, would you be using it? That's probably the best way to vote on this. So I think everybody here hopefully has their voting apparatus. Gentlemen, are you ready for the vote? Yes. Decide? Good. Okay. So you have multiple buttons on there, but this is going to be an A or B vote. If you press A, that means you're voting in favor of Dr. Jaffe's pro position. If you vote B, you're voting in favor of Dr. Parchand's con position. So A for pro, B for con. Vote now, please.
I won.
Every vote yesterday came this way.
Okay, well, we're going to move on to the next presentations. And as I had mentioned, we've switched the order to accommodate some flights. And the first of we're going to be talking about the dislocated intraocular lenses now. And the first of these is the pro position from Dr. Ramandeep Singh, and the con position will be given by my co-moderator, Dr. Michael Stewart. So Dr. Singh, you can lead off.
Good morning also. I've been given this task of defending this repositioning better than the replacing. So I will straight away move on to what are the disadvantages with the exchange there. So you have to take out an IOL there, either you enlarge it to 6.5 millimeter corneal incision and take it out, or you put in a big Vana's scissor inside and cut it in the middle, and next morning have a lot of corneal edema superiorly, and and tell the patient it will go away, and pray to God also. And you're maneuvering the lens from the posteriorly to anteriorly, or likely to damage iris, the cornea, endothelium, and a new surgeon can even kill the cornea in these patients. So IOL rescue is a possibility because there are certain designs which we use, and this can happen in practically all the situations. So I will now let my actions speak for me. So I will show you some videos there where I do this. Depending on the capsular support, I will plan that I can put these IOLs back in the capsular support by bringing the IOL from behind to posteriorly. This is a surgery done with a lot of patience because you have to literally find all the capsule which is left over by our cataract colleague. So because they do beautiful CCCs, probably sometimes they are there. So you can bring it from behind and put these IOLs, either it's a PMMA lens or a three-piece lens. This is what they do. So this is done in one situation nicely. And this is another videos because now we have this support. There's no capsular support there. So what to do there? So you have these pair pack sutures, and then you have this now new technique of tucking them into the sclera, which was given by Dr. Agarwal, the glued IOLs there. You can easily do it. And then you have the Yamane's technique. Both the techniques are very well, they're reproducible and can be done in these patients. And somebody wants to do, can first go to the wet lab, try it in the goat eyes, and these can be done beautifully in these eyes with good results because nobody's touching these iris, nobody's going near these cornea. And this is one, I'm doing a Yamane there in such technique. So this is you don't need to tucking, you don't need glue there. You are practically using the scleral track to put that haptic inside. Little more, learning curve than the glued IOL. So, but it can be done. It's a doable surgery because you are not bringing out the IOL in these patients, and you can easily do it in the wet lab, and then you can move on to the patients because the results are very good. You are not replacing, you're repositioning the same IOL there. And then there's another one. Now this one, I don't know, are you able to see? There's an IOL there with the pair pack haptic has broken there. So I'll be showing a video that one haptic is already, can I have the video please? Excuse me? Video. You said you'll help me. So one haptic is, still, tied to the sclera. The other haptic, the pair pack has given away. And what to do? I mean, this is, you can reposition these IOLs without taking them out. I'll be just showing a cartoon there. This is how we went. And with the forceps, you bring in that one haptic ahead and just hold it. And one side, you make a scleral flap, and you go in with the pair pack, long needle, and pass through the eyelet there, and take it out from the other side, limbus, and then you go back and just, you'll see that I will go back through the same track, but this time I will not go through the eyelet. I'll miss the eyelet, and I will just put that thing there and tie it, and they do very well in these patients. It's a minimally invasive surgery, and you are able to do this. I'll be showing you this case which I recently did, and this is one such case. This is a perforating eye injury, foreign body removed, lensectomy was done, and later on TSI file was put around 6 years back. So this is an IOL there. Like I said, I will hold the haptic with the forceps there and the switch hands, and then I will, like you see, with the long pair pack needle, I'll go through. You can see the old pair pack suture there. I'll go in and bring out with the railroad technique from one side, And then similarly, you'll see I'll hold the haptic there so that it doesn't go with it. So there it comes out, and then I told you I follow the same track again, and this try to come out. Again, real load technique, you use this 27 or 26 needle and just take it out, and just you have your pair pack sutured scleral IOL is back in place, and which will probably work for a decade or more. So this is the OCT, the IOCT showing the place of the IOL and where we are taking care of this patient. So so the issue is now the single piece IOLs. You know, the single piece IOLs. 2 slides more. I'm sorry about this. So issue is single piece used to be absolute contraindication in the sulcus because it used to cause UGH syndrome. But with the newer models and considering the age of the patient in 80s, you can try this thing. I mean, I have not shown you the videos because the controversial thing, I still believe they called UGH syndrome. But I have done for few very old age patients, I put a single piece IOL in the sulcus also. So the concluding slide is what can better be for the repositioning. Complication of cataract surgery can be managed with minimal trauma to the eye. Thank you so much for your patient hearing.
Okay, thank you. Could I have my slides, please? So I'm going to be debating the no side of this question. Dr. Singh has given us wonderful videos, and for an excellent surgeon like him, repositioning is, under certain limited circumstances, depending on the implant, it is a wonderful option. For the rest of us, I'm not sure that repositioning lenses is something that we want to incorporate into our practice on a routine basis. So replacing the lens as opposed to reusing, A, is technically easier, B, can be done with more surgical options, and C, gives equivalent or better results than reusing. Just because you can position the IOL doesn't mean that you should. They're more difficult, and I'll call you back to Dr. Relya Zivanovic, who was a tremendous vitreoretinal surgeon from Europe. His statement was, you must control the fundus. So I'm going to paraphrase him and say that when you're dealing with an IOL, you must control the implant. Suturing an implant while inside the eye is technically a very difficult thing to do. Having done that in the past when I was younger and more foolish, I can attest that though it can be done, it's not something I want to base a career on. So what might be the advantages to repositioning? Well, fewer, smaller incisions. Does it really matter? We have good sutures. We can close eyes just fine. Preventing astigmatism. But to bring a lens out and put it back in through a 5.5 millimeter scleral tunnel really doesn't cause very much astigmatism. Preventing anterior chamber corneal damage, as Dr. Singh alluded to, for most studies show that whether you have anterior, posterior chamber removal, it doesn't make a difference, so I will show you some data where it's a minor difference. Shortening the procedure. The answer is, yeah, potentially does shorten the procedure by not having to make multiple wounds, but I call back to really what we do here is the interest of the patient come first, and having a predictable, accurate procedure supersedes the length of the procedure itself. And finally, avoiding the use of sutures. It's inexpensive, rarely causes problems. I want to point out this, that in most cases of IOL dislocations, you're not going to have an implant that's compatible. And Dr. Singh did tell us that the SN60WF, or the one-piece acrylic lenses, which is lower right in this photograph, are really not very compatible with replacement, nor are crystal lenses, nor are silicone lenses. He showed wonderful videos, but every video contained either a 3-piece IOL or a 1-piece IOL with loops on them. And I will contest that those are the ones that are best for reusing, but those are a minority of the IOLs that we will ever come across. Other lenses like these are the ones that can be used, but again, the technical difficulties of suturing inside the eye probably supersede the advantages of removing the lenses. The SN60WF in the United States is far and away the most common lens that's being used. These lenses are very difficult and in fact probably should not be sutured. They don't do well in the ciliary sulcus, though a series of 7 cases has been reported. In my hands, I would not want to try to do these because of the difficulty of suturing, to externalizing the haptics, and as Dr. Singh himself suggested, the possibility of the uveitis glaucoma hyphema, or the UG syndrome. And I will draw your attention to the package insert on these popular lenses where it says that there is no efficacy data to suggest that this works well in the ciliary sulcus. Successful surgery is all about having viable options. Just because we're vitreoretinal surgeons, don't forget the anterior chamber is a very good place for an intraocular lens. And in most of these cases, the only way you're going to get one there is to remove the IOL and put an AC-IOL in. Very stable and has comparable long-term results to any sutured PC-IOL. In fact, when you look at the data in the literature and you compare AC-IOLs to PC-IOLs, and that's what some of what we're comparing, is that in the majority of cases, there's absolutely no difference in long-term acuity results or in complication rates. Two articles were exceptions to that. One showed an advantage to the AC-IOL, one showed an advantage to the PC-IOL. So finally, let's talk about head-to-head comparisons. Two studies have looked at reusing versus replacement of dislocated in-the-bag IOLs. This study showed equivalent visual acuity results in the long term. However, the eyes that were reused, 3 of the 6 had to be replaced because they ultimately dislocated. And that, even though in a small series, was statistically significant. And the second study was a prospective randomized study of 104 eyes, scleral suturing versus iris claw, reusing versus replacement. Every parameter here on visual acuity and complications were the same. The only difference was corneal endothelial cell loss. Slight advantage to the reuse versus the replace, but at 3% versus 10% endothelial loss for the vast majority of corneas, that's not going to be statistically significant or clinically significant for the lifespan of the patient. So an old medical adage, good medical practice comes from good judgment comes from lots of experience, and lots of experience comes from lots of experience. So can you do these maneuvers? Yes, but I would say in your practice, do what is most predictable and what you feel has the lowest complication rate, and use that for the majority of your cases. So I suggest vote no on this issue. Thank you.
Thank you very much. I think both of the contestants gave a compelling argument. Dr. Singh pointed out the large incisions, the need for maneuvers that could potentially lead to corneal endothelial loss, and showed a variety of different techniques for repositioning intraocular lenses that may have become dislocated. On the other hand, Dr. Stewart showed that the number of lenses that can be replaced by this method is a relatively small fraction of the ones that are actually placed in the eye, and that it's a reproducible method to put it in the anterior chamber and gives predictable results using known surgical techniques. And so at this point, I'd like to call for the debate. And A is going to be, call for the vote. A is for the pro side for putting in the repositioning the lens, and B is for Dr. Stewart's point, which is to replace the one that's in there with a different intraocular lens in the anterior chamber. And Dr. Stewart took the debate.
Okay, so next we're actually shifting the order here in order to accommodate further people who have travel issues, and we're going to the 12:05 debate, which is on Amsler grid should be given for home monitoring. Taking the pro or the yes position is Dr. Paritosh Kamdar, and taking the negative or con position is Dr. Mansi Sharma. So Dr. Kamdar, you would start, please.
Please have. Good afternoon, good morning, everybody. All of us are very familiar with the Amsler's grid. It's been used for almost 70 odd years. Each tiny square subtends an angle of 1 degree at the level of the macula. There are 7 charts. We are all aware of these as well. The Amsler's chart is a rapid screening tool only. The conventional used one is a supra threshold, but the more commonly used one by the patients is the black lines on a white background, and that's actually more like a threshold test. It has high specificity, though the sensitivity can be low, but the common one which is used increases the sensitivity also. And discrete metamorphopsias, small scotomata, they all get picked up once the patient has been educated and understands the test properly. It can even pick up certain defects because of rest of the visual pathway, provided they fall within the central 20 degrees, and is useful for detection of different types of maculopathies, retinopathies, other retinal impairments, and even optic neuropathies. The advantages are low cost, it's quick to perform, easy to explain and understand, and has the ability to detect both scotomatas and metamorphopsia. The most important thing is that the mere act of understanding how to do an Amsler's test triggers in the patient a self-learning process and a better understanding of one's own disease process, which contributes quite a lot in the overall management of the patient. Threshold testing has consistently, in fact, produced a 5-fold increase in detection of visual field loss and defects. Now, because literature is reft with a lot of conflicting reports, I said, let me do my own simplistic survey. So we formulated this kind of a simple questionnaire. Have you understood the procedure of the chart? If yes, have you done this test every weekly as advised? If no, what action did you take to understand this test? And did you read the instructions given in the file along with the chart handed over to you? If you still didn't understand, did you call up the clinic to figure out what you didn't understand, or did you come back in again, and so on? And have you noticed any changes? Do you find this test useful, and so on? And for people who did not do it, what is the reason for your reticence to do this test? Forgotten to do, laziness or carelessness, or lost the Amsler's test itself and didn't ask for a new one, and any other comments. So what we found in the last 100 patients who came to our OPD, we just did a cross-sectional simplistic study, retrospective study. 74% found it useful, of which 3 found it extremely useful, 24 were not doing it, 12 because of a careless attitude. Now this 74 which people who found it useful, of that 5 were from the other side but got converted merely because they called up the clinic, visited the clinic and understood. 2 patients were ambivalent. All of us know that so far as retina and especially the macula is concerned, early detection leads to early diagnosis and early treatment and gives us the best visual results. So, if I were to ask you, if you had a simple piece of paper that costs 1 rupee, that had a 50% chance of detecting macular and some optic nerve abnormalities as well, even before your patient became symptomatic, and which he could do at his own home, at his own convenience, as against a device that had a 75 to 95% chance but cost so much that only 0.1% of your patients would actually procure the device, what would you choose? I think the answer is obvious. An Amsler's in hand is worth 2 PHPs in the bush or the clinic, and something is better than nothing. I rest my arguments.
Very good. Thank you very much, Dr. Kamdar. And giving the con to this argument on Amsler grid is Dr. Mansi Sharma.
Thank you. So, as Dr. Paritosh rightly said, but I will be trying to convince you against Amsler's, so let us start with it. I would like to start off by saying absence of evidence is not the evidence of absence. What is the aim when we hand out a chart to the patient in the clinic? What are we trying to achieve? We are, number one, as Dr. Paritosh already mentioned, trying to detect, can you hear me, right? We are trying for an early detection so that we can give patients an early option of early treatment. Hence, what we're aiming at is the ability of the patients to accurately detect changes in their vision and seek immediate referral, which is of the paramount importance. Now, how can we assess a diagnostic tool? So the purpose of a screening test, the criteria for an ideal diagnostic tool is that it should be sensitive as well as specific and strike a perfect balance between the two. Now, if we want to talk about Slurs Chart sensitivity, the sensitivity, as has been reported in a lot of studies, is pretty low as 56%. This means that we are failing to identify patients who do have the disease, and this is linked to the false negative results. Hence, we are not offering the patients who do need treatment based on this test. Sensitivity in another study has also been shown to vary between a low figure of 9% in early AMD to 34% in late AMD in patients with choroidal neovascularization. And it is pretty clear from all these trials that this data, that a significant proportion of patients with macular disease will not be identified solely by the Slurs Chart. Coming on, talking about the specificity. So Slurs Chart has been shown to indicate the presence of scotomas in about 2% of control subjects without any scotoma or without any actual problem in the eye. So what does a low specificity mean for a test? This means that there is a high proportion of subjects who are identified as having the disease when they are healthy, and this is associated with a high false positive, which overburdens our secondary healthcare systems and causes unnecessary risk tests to the patient. Now, what is the reason behind such high false negatives? So we'll try to go into the physiology a little bit. There are several possible explanations which have already been given, including use of a preferred retinal locus away from the scotoma boundary by the patient, averaging of the crowded stimuli, and asymmetry of attentional deployment in peripheral retina. In totality, it means even a patient with scotoma won't detect it because of all of these physiological variations. And also there is this phenomena of natural magic has been described, which is filling in, which basically is perceptual completion of an image by the person at a cortical level, even when there is an actual scotoma. That is the reason why we don't all see our blind spot. Now, one may argue it's a physiological thing and may not develop in pathological scotomas, but we have studies which have reported this phenomenon of perceptual filling in happening in pathological scotomas as well, suggesting it can occur in immediate rather than being an adaptive process. So my arguments are that perhaps the most compelling reason for this test variable sensitivity is the remarkable capability of the brain to complete missing or out of line details, whether they be pathological or physiological, which could cause slight distortions to pass undetected. Additionally, Slurs grid do not provide precise quantifiable measure of visual field defect and are therefore not useful as monitoring tools for disease progression. Of course, if we are discarding it, then we need a replacement. So we have newer tests coming in, including preferential hyperacuity meter, which is a computer-based screening test. And in studies comparing it to Slurs, they have found them to be equally good or even better. And specificity of PHP, though, is on the lower side, but the sensitivity is more, so at least we are not missing out on patients who actually have the disease. Another newer technology is the virtual retina display, which combines a scanning laser device with virtual retina display and projects the dynamic visual noise. And it also has a good sensitivity and a very good specificity of nearly 100%. However, one may argue these involve use of sophisticated tools which are expensive in a hospital setting or at home. Expense and training required in detecting the scotomas make it impractical as in home-based screening tools. So we all know about the environmental answer. So we can all be environmental friendly rather than handing out papers. I know it's just ₹1, like I said, but there's so many patients with AMDs, and when you in totality want to take out the cost, I think we are doing more harm to the environment than good. We can just simply tell the patient to do environmental Slurs at home rather than handing out a paper. So, which is more practical, acceptable to the patient. We can just ask them to look for straight lines that are already present in their environment, keep monitoring them. Any distortion in that, they can easily go to their retina person and report. So in conclusion, as far and more better treatments become available for neovascular AMD, importance of early detection cannot be overemphasized. Although the Slurs has the benefit of being straightforward, cheap, and easily understood by the patient, the very high false negative means that we should be very careful in interpreting the result. Thank you.
So thank you very much to both of our debaters. So to summarize, Dr. Kamdar on the one side says that though we have data that shows that there is utility to using this, the numbers are low, but this is better than nothing, and the alternatives are not available, certainly not going to be available widely to the Indian public because of cost concerns. Dr. Sharma argues the same numbers, and she takes the other viewpoint, and the viewpoint is because of the large number of false negatives, even though there is some sensitivity to this, the large number of negatives means a large amount of false reporting and it overburden to the health system. So in the US, when we have two people who are arguing exactly the same numbers from different standpoints, we tend to say one is debating and saying the glass is half full and the other is saying the glass is half empty. They're saying exactly the same sorts of numbers. So the question for the vote is, should the Amsler grid be given for home monitoring, as Dr. Kamdar has argued, or should it not be, as Dr. Sharma has argued, from the perspective of environmental testing, and subsequently with the hope of using more advanced devices such as PHP. So the vote here is A and B on your device. A is a vote for pro for Dr. Kamdar's position. B is a vote for con, Dr. Sharma's position. So go ahead and vote now, please.
Very good.
Thank you.
So the next of the debates is going to be based on non-center involving diabetic macular edema. And the first position is going to be by DaraiusShroff, who's going to be making the point for laser photocoagulation. And the second point will be made by Thomas Cherian, who's going to be discussing the use of anti-VEGF for this same condition. So Dr. Shroff, if you can lead off, please.
Thank you, Dr. Jaffe. So I would like to emphasize on my first slide the words non-center. So let's wake everybody up. We can have a new audience poll. As far as possible, in my practice, I'd like to practice evidence-based medicine in my clinical practice. You can just have a raise of hands. How many people say yes? Just raise your hands. Do you want to practice evidence-based medicine or you don't? So there my debate ends. Anti-VEGF agents have not been tested in any of the rigorous clinical trials for the treatment of extrafoveal or non-center involving DME. I would like to rest my case, but I would go on a little bit. So the landmark study that establishes focal laser for DME is the ETDRS. ETDRS matters. It's found a 50% reduction in moderate vision loss patients post-laser, and you can see it even gets better with time. At 3 years, from 33%, this went down to 13%. This is the landmark article published in 1985, which shows this. And what is important for our debate is this article included patients both with foveal center involved DME and non-foveal center DME. So that means focal laser has been proven for both. And I'm only arguing for non-foveal center including DME, which is a no-brainer really. My worthy opponent wants to inject anti-VEGF agent for non-center involving DME. What does this mean? So I'll just give an example. A 55-year-old man with 12 years had diabetes for 12 years, came for a routine fundus exam, vision was 6.6 and 6. You can see some hard exudates and microaneurysms away from the center. This is the angiography showing these lovely microaneurysms lighting up. And option one setting a focal laser. Option 2, anti-VEGF, God knows how many. We just do a simple focal laser and you get good response to the laser. Let's be ethical. Let's be ethical to our patients. Let's have less visits for the patient. Single visit versus God knows how many sittings of anti-VEGF agent. Of course, laser would be much, much cheaper for our patient. And also laser, there's no opportunity for post-injection endophthalmitis. Of course, it's very, very rare, but it is a reality we all have to face at certain times. Our worthy opponent seems to have forgotten the oath we took in medical college, the Hippocrates oath. It says, you can see Dr. Google has helped me get that original scroll on it is written, and you can say, it says, first, do no harm. Let's not do our harm to our patients. Of course, showing that scroll now, my worthy opponent will say I've turned into a dinosaur, pulling out all these old studies from 1985. But no, Dr. Scott and Dr. Bressler have me covered. In 2009 in Retina, the DRCR net studied this, and you could just have to read the conclusion of this article, which says that ETDR recommendation to consider focal laser in non-center involving CSME still seems appropriate. 2014, there's another study which suggests early intervention with focal laser in eyes with non-center involving macular edema. Let's be in the real world. Let's not fool ourselves that studies are everything. So this is one of the slides given to me by Dr. Abhishek Kothari, where they studied the amount of patients lost to follow-up. So if you see on the right side, they have studied the difference between AMD patients and DME, and you can see what a large percentage of no-shows there are in the DME patients. So these are patients who are not going to come in again, so why not just treat, especially if the vision is good. So why not just treat them and let them not get any more harm with the simple laser treatment. Let's be ethical, let's be compassionate, let's follow evidence-based medicine. Please vote for laser. Thank you.
The counter-argument will be given by Dr. Thomas Cherian, who will discuss anti-VEgF use for this same condition.
Good morning. My friend Dr. Darius has tried to do laser for a non-center involving DME with a flimsy piece of evidence which is 33 years old, and he has tried to substantiate it with two other bits and pieces which he calls evidence, which came down in 2009 and 2014, which also clearly states that laser still holds good for non-center involving DME. That means 9 years down the line, situation has changed, and it's ever changing as if everything in medical science. Non-center involving DME, we have two options as per this debate. One is the laser, which Dr. Darius has tried to justify, and the other is AntiVEGF, which is the in thing in modern medical retina practice. Let us see what Dr. Darius has done with his patients while doing laser. Look at this picture. It's a beautiful scenery, and once this patient has a non-center involving DME, what does he have? Go to this. It's not in the center, but he misses out quite a lot. And Darius tries to do a laser for his patients, and this is what he does, cuts it off. Or in the most, in other circumstances, he might still run towards the fovea and do this. This could run towards the fovea. That means he's cutting off everything which is not at the center. While I give AntiVEGF to my patients, and this is what my patient has. So what do you want? Cut it off with laser or repair it with your AntiVEGF. Let's go through a few non-center involving DME scenarios. This is one where the patient has a macular ischemia with a non-center involving DME. When there is a macular ischemia, it's common knowledge, it's primary teaching that you do a laser, you increase the area of ischemia and increase the patient's scotoma. When you have a non-center involving DME with a few cystic spaces involving the fovea, if the vision is compromised, intravitreal AntiVEGF can be the treatment of choice. If the patient is symptomatic and the vision is good, still AntiVEGF is the treatment of choice. So you're left with no choice but AntiVEGF. When you're going into an OCT-based treatment in non-center involving DME, in a non-center involving DME that is clinically significant, if the subfields adjacent to the center are red or worse, start treatment with AntiVEGF and do only a micropulse laser, if at all, when the OCT shows the central subfield as pink or better, no thermal laser. What are the undesirable side effects of lasers in DME? Progressive enhancement of laser scars. There could be an atrophic creep due to enlargement of laser scar, can result in impairment of visual acuity. Use of small size, short duration intense laser can lead to destruction of the Bruch's membrane and formation of a choroidal neovascularization, which could again compromise the vision. The potential complications from the classic ETDRS level treatment, in particular the relatively high risk of paracentral scotomata. Laser-induced damage to the retina is permanent, and accidental burn to the fovea during focal laser for DME is reported. My dear friend Darius, when you and I were trained in doing laser, It was probably the era where anti-VEGF was not there or was just coming in, so we were trained to chase and hit the microaneurysm extremely close to the fovea. You could still do it. I might be able to do it, but not my fellow or my trainee, who is trained not to go close to the fovea, but inject whenever there is a risk. So take a step back and consider your patient's perspective. You have just been diagnosed with a macular edema. Would you rather receive a laser treatment that will leave you with permanent side effects or get injections in the eye? Patients should be educated about the available treatment options and the benefits and risks of each. So my choice for a non-center involving DME is certainly anti-VEGF. Thank you.
He also made the point that doing laser doesn't cause injection-related side effects, for example, endophthalmitis, and that in addition, the patients who are given anti-VEGF therapy at a high rate are lost to follow-up, and you don't know what actually happens to them. On the other hand, Dr. Cherian made the points that the older evidence that Dr. Shroff has used is not in keeping with the times with the more recent advent of anti-VEGF therapy, that even when you have non-central involving macular edema, patients still have decreased visual acuity, and you're potentially making that worse with laser, which can cause creep or scotoma, and you actually have the chance to make the vision better with anti-VEGF therapy. And so for those reasons, and others, he would side with anti-VEGF therapy. So it's time to take it to a vote, and Dr. Shroff is the A position that focal laser photocoagulation is appropriate for non-center involving macular edema, and B, Dr. Cherian's position that anti-VEGF therapy is the best choice. So choose A for Dr. Shroff, B for Dr. Cherian. A's have it.
Okay, very good. So two more debates before we terminate this morning. So the next debate is going to be, the question addressed is combined anti-VEGF and corticosteroids for diabetic macular edema. Given the pro argument is going to be Dr. GopalPillai to my right, and giving the con argument is going to be Dr. SandhyaMakhija, who is going to be on my left. So, Dr. Pillai.
Thank you very much. First of all, let me thank Dr. Vaishali and VRSI for giving me this opportunity. I'll be speaking on combined anti-VEGF and corticosteroids for DME. Even though I am injecting multiple injections, there are no financial interests for this. Now, imagine this particular situation, clinically significant macular edema, where you want to do the best for this patient, and you know that it is not a war in 1 day or 2 days or 1 month or 2 months. It's going to be a 5-year-old, long battle which requires to be won. So it's not about giving one injection monotherapy for some days. It is always about using all the options that you have in order to win a war with this particular condition. If you're only looking at anti-VEGF injection, it may not work. Probably you will have to look at something like this. My worthy opponent will be telling that you will be facing it just with one particular, managing solution, whereas we require all. Imagine this particular patient whom from 2007 I had been following up, had got about 20 anti-VEGF injections before I got one shot of Ozurdex maybe in 2012, and you can see that the hard exudates completely vanished out of the eye, and my number of injections reduced significantly. So that's the beauty of combined treatment. Why should we combine? There are theoretical factors, available evidences, number of injections we should look at, side effects we should look at, pseudofakes versus fakes. We should do a small cost analysis and finally look at simple logic. We all know that a lot of cytokines other than VEGF are actually involved in diabetic macular edema. These are some of them. Cytokines, TNF-alpha, IL-6, IL-8, IL-10. A lot of cytokines are actually involved in diabetic macular edema. So these are some of the cytokines which are actually present in diabetic macular edema. IL-6, IL-8, IP-10, MCP-1, all these things are actually present. And there was this particular study in which we looked at what happens when an anti-VEGF is given. You can see that the VEGF is reduced significantly from 1,000 to about 100, But a lot of other cytokines are actually on the increase, which tells us there is a upregulation of most of the cytokines even after an anti-VEGF injection. Like, for example, the IL-6 from 81 it increased to 1000, IL-8 increased, TGF-beta 5500 to 8000, which are all statistically significant increase. Now, let's look at what happens with the triamcinolone versus bevacizumab. You can see that all the interleukins were actually reduced with triamcinolone, but VEGF did not decline as much. Whereas with anti-VEGF, VEGF declines significantly. None of the other cytokines are touched. So we have one side anti-VEGF injection which would significantly reduce the VEGF, and we have on the other side steroid which can reduce almost all the cytokines, not so much the VEGF. So what about anti-VEGF non-responders? So there are lots of studies which says that about 40%, 20% they are non-responders. Let us look at some of the studies. This is protocol I. About 32% of them were non-responders based on OCT. And about, there are a lot of people who are visually significant non-responders as well. Just like that in protocol T, you look at bevacizumab, a lot of them are non-responders. Even Afilbercept and Lucentis, there are a lot of non-responders. Corticosteroids have a broad spectrum of biological action, so that is why I would say that, corticosteroids may be necessary to be added with anti-VEGF. Yes, we have cataract and glaucoma, but as we saw in the real-world evidence, which was presented a little while ago by Dr. Chabblani, the incidence of glaucoma is so the surgically treated needs are very low. Combination therapy definitely is here to stay. Now my learned debater will be talking to you about Protocol U and how Protocol U said that there was no significant difference between the two groups of anti-VEGF alone versus anti-VEGF with diabetic, corticosteroids. This is what she would say. There was no significant difference. But let's go into pseudophakics versus phakics. In the pseudophakic eyes, these were eyes who received 6 anti-VEGF injections and then went into combined treatment. And even after 6 anti-VEGF injection monotherapy, when they moved into combination, the pseudophakic eyes increased by 5 letters, which means that there is definite evidence that combination treatment would improve the visual acuity. Now, sooner or later, in this five-year war or battle, you are going to take the cataract off, and then that benefit will definitely come into the patient. Now, what about more than 15-letter improvement? After 6 injections of anti-VEGF, when you move to combination therapy, 11% of them increased by 15 letters, as opposed to ranibizumab alone group of 2%. Again, outcomes of the lens status. So all this, I would want to say that macular thickness also significantly reduced in the combination group. So addition of dexamethasone is significant. So I want to show one last slide about cost. When you add a steroid, probably the number of anti-VEGF injections that you have to do would reduce significantly, and that would also significantly reduce the costs. Anti-VEGF is smart, but when the opponent is diabetic macular edema, you require combination. And so in all fronts, combo therapy will win as opposed to monotherapy. Common sense is a flower that does not grow in everybody's garden. I wish my debater all the best. Thank you.
Good show, Dr. Pillai. But before I start my, which one, I think, okay.
Thank you, Dr.
Before I
Pillai.
start my debate, I just want to ask you something. Suppose one of your family member comes with fever or respiratory infection, you don't know which pathogen is there, and you know that about 10, 20 antibiotics are available with you. You will start with one or all?
No, let's get the debate pattern down. So that's part of your debate, but he can't respond. Go ahead.
Anyway, so let's see the diabetic pathology. Diabetic macular edema is the most common cause of visual loss and in diabetic patients. And there are various pathophysiological agents, like he rightly said, and I agree with that. And if untreated, it leads to visual loss. Until recent years, macular laser photocoagulation was the only available therapy. Inflammation is an important factor in pathogenesis, yes, of course, which gives us, the advantage of intravitreal corticosteroids as a treatment method. Anti-VEGFs also brought revolutionary change, and it gives intravitreal anti-VEGF agents. We have seen, wonderful results with this. So if we see the diabetic pathology, the entire course of the disease is very long. Single treatments are just not effective enough. We need to give multiple repeated injections, whether we give 1, 2, or 3, or whatever agents we give. So what is the protocol, the method of treatment? We really don't know. We haven't even, no one has really said upon one protocol to follow. We have seen short-term trial outcomes of ranibizumab patients with visual impairment due to DMEs and various trials like Resolve, RE2, DCRNet, and Restore. In all those cases, we have seen very good results with this. We have seen long-term trials also with the same ranibizumab. All these trials have shown good long-term results also. Corticosteroids have been widely used to treat DME. It is targeting VEgFs as well as inflammation, whereas anti-VEGFs target only angiogenesis. It stabilizes the junctions between endothelial cells and blood vessels. There have been various studies which have shown inflammation and a good resolution of inflammation and diabetic macular edema by Ozurdex by these various studies. So I'm not going into details of these studies. Clinical trial by Solin et al. Has compared results of various combination treatments, and they have found no significant differences between bevacizumab and combination groups also. There's a review article, big review article by Dina Zur and Annette Lowenstein in Journal of Ophthalmology on combination therapy for diabetic macular edema, and it clearly quotes that though intravitreal corticosteroids and anti-VEGF drugs have different ways of action, there was no injective effect found with combination therapy. Combination Ozurdex and Lucentis versus Ozurdex, this has been trial. The results are awaited. This is being done by Allergan people. So what is important for the treatment of diabetic macular edema? We have to aim towards stabilizing visual acuity ultimately. We have to reduce retinal inflammation, reduce hyperpermeability, protect neural cells, and we have to bring this picture to this picture. Simple. If you see a diabetic patient, the calendar of appointments is full of, visits to nephrologist, ophthalmologist, endocrinologist, diabetologist, and all this. It's such a big burden for the patient, family, financial burden. The patient is anyway so, weak and handicapped, and then you give so many injections. And so it's a big financial burden to the family also. He's dealing with lots of handicaps. Why add on to financial burden? Both patients and the family is suffering. Repeat injections have to be given anyways because it's an ongoing pathology. And studies have shown no added benefit of the combination therapy. So why not follow a scientific approach? We should know that what is working, not an umbrella approach. Okay, give everything that's available. Why? Not expose the patient to double risk of side effects, double pricks. It's a cost factor that is being involved. Give one agent, wait for the response. You can anyways give another agent after 3 months or something, and anyways repeated injections have to be given anyways, whether you give one or two agents in one go. I would say about 90% practically. He has said 60, 70% or something. But I think about practically 90% of cases, either one of the agent is working pretty well. Some cases are anyways refractory. So we can very well plan to give one agent, any one agent, depending on the surgeon's choice, whether we give anti-VEGFs or dexamethasone implant, depending on the case that's there, and then see the response, and then switch to another agent next time if it is required. Repeated injections are anyways required. So I will go for monotherapy, although we are friends, we are all friends, it's his opinion, so let's see what we all have to say about it. Thank you.
Okay, so thank you to both of our debaters. So the arguments put forward here are, one, that diabetic macular edema often is a disease characterized not just by elevated VEgF levels, but also elevated cytokines, although clearly the two debaters differ in terms of the importance that they ascribe to the other non-VEgF growth factors and cytokines. So Dr. Pillai talked about recalcitrant cases. He did go to Protocol U, and he said that the combined group did have a better drying of the macula than the monotherapy group. And though the visual acuity results were not overall different, he did say that subgroup analysis was important before you throw out the idea that combination therapy is not superior to monotherapy. Dr. Makhija talked about the efficacy of long-term anti-VEGF therapy, which we know from phase 3 trials with both ranibizumab and Afilbercept have been very encouraging. And she also then contrasted Dr. Pillai's position by saying that several trials of combination therapy do not show a increased efficacy over monotherapy given with anti-VEGF agents. So we'll now put this to a vote. And if you go ahead and take out your voting apparatus, please. The A vote is going to be in favor of the con side, Dr. Pillai. The B vote is going to be in favor of the negative, which is Dr. Makhija. So if you go ahead and vote now, please.
All right. Very good.
Thank you.
So in our concluding debate, and as I understand it, this is a very unique situation because we have a husband and wife arguing opposite sides of the question about new diabetic hemorrhage, 1-week-old, prompt vitrectomy, yes or no. Now, I don't know who wins the arguments at home, but you're going to be able to see in a public forum who gets to win this debate. So taking the pro position for a prompt vitrectomy is KanikaAgarwal, and the con will be AntiVEGF. So Kanika, if you could start, please.
Thank you. Very good morning. I will be speaking in favor of PPV for a new onset diabetic vitreous hemorrhage, a prompt vitrectomy. So what was known 3 decades ago, from the evidence which is published in literature, we all know that PPV is indicated for a non-clearing vitreous hemorrhage in diabetic retinopathy. And the DRVS study, that is the diabetic retinopathy vitrectomy study report 2, showed us in the 2-year results that patients in the early vitrectomy group had a better chance of a better visual acuity compared to the patients who were in the deferral group. So there was a clear-cut advantage for early vitrectomy in type 1 diabetes, and no such advantage, although was found in type 2 diabetics. And in the 4-year results of the same study, they again maintained that early vitrectomy in severe vitreous hemorrhage helped in increasing the chances of restoring or maintaining good vision, especially in type 1 diabetics. Again, in a study in 1986 in ophthalmology, the timing of vitrectomy for active proliferative diabetic retinopathy was studied, and they showed that early vitrectomy helped an improved anatomic success rate, 85% compared to 73%, and a higher rate of reading visual function in the early vitrectomy group. So again, in the 3 decades back, there was evidence in favor of early vitrectomy. So what is different in 2018? Now, this is the era of small gauge newer instruments. We're talking about ultra-wide 10,000 rate vitrectomy probes, and which offer us a much safer vitrectomy, lesser complications, and much better results. This is a video that I have borrowed from Professor Vishali Gupta, and this is showing the ultra-wide cutter with the 10,000 cut rate and the beveled entry. So this provides us very safe vitrectomy, and we no longer fear the complications which were earlier happening with the older vitrectomy techniques. A recent study in 2018 which evaluated the cost of treatment, so of early vitrectomy versus pan-retinal photocoagulation and intravitreal ranibizumab for proliferative diabetic retinopathy, actually has said that early PPV as a strategy for treatment of PDR without macular edema demonstrates cost utility similar to management with PRP, but is more favorable compared with intravitreal ranibizumab in the short term, and this advantage continues when lifetime costs are factored in. There are studies which also show the benefit of inducing a posterior vitreous detachment during PPV in treating or preventing a DME recurrence. So this further increased the cost benefit of this treatment. And also, studies have shown that in treatment of vitreous hemorrhage for PDR, up to 1/3 of patients may need PPV despite treatment with intravitreal ranibizumab. So if we are doing a prompt vitrectomy, actually we are saving the patient from a future complication. So this is just a representative case. This is a patient who presented with a 10-day-old vitreous hemorrhage, and this was the vision, and the FFA did not reveal much because of the hazy media. And after vitrectomy, after a prompt vitrectomy, the patient, this is the 1-year follow-up, the patient maintained a good visual acuity. We could do an adequate laser for the patient, and there was no recurrent vitreous hemorrhage, and he maintained a relatively dry macula. This is a similar second case, a vision of 3/60, and we could see that at 2 years post-PPV, again, he's maintaining a good vision with adequate laser, and the number of visits of the patient as well as the cost of treatment is greatly reduced because of a prompt vitrectomy. And another situation where prompt vitrectomy is very important is where you can see this is a case where a previous PRP has been done, but it cannot prevent always the recurrence of hemorrhage with a subhyaloid bleed present here and a separating hyaloid. So in a situation like this, instead of flogging a dead horse and trying to give intravitreal ranibizumab or trying other therapies, we just go in for a prompt vitrectomy, and we can just clear the hemorrhage and supplement the laser and give a good outcome to the patient. So to summarize, these are the scenarios where I would opt for a prompt vitrectomy for my patients with new onset vitreous hemorrhage. One, if the vitreous hemorrhage is very dense with a poor vision on the first visit, or in the presence of a tense premacular bleed, I do not want to delay a definitive treatment. I would go for a prompt vitrectomy. A new onset bleed where the patient already has a pre-existing mild hemorrhage which precluded an adequate laser, I would go for, when there is a new hemorrhage in such a case, I would immediately go for a PPV. And the third is when there is a pre-existing pathology such as a taut posterior hyaloid or significant fibrovascular proliferation, I would go for an anti-VEGF because, I would go for a PPV because a laser would be contraindicated in such a situation, and anti-VEGFs will not be able to address the problem in totality. Thank you.
So the con argument against an early vitrectomy will now be given by Dr. Agarwal, but this time Aniruddha.
Thank you. So my position here is no vitrectomy for 1-week-old vitreous hemorrhage, and I have, of course, several disclaimers here. Dr. Romano could not make it to VRSI, and I think inadvertently has put me in a very difficult situation here. And I think while all of you are having great fun at VRSI, things might not be the same for me back home. So you exactly know why I will not report to work tomorrow, if at all. My point here is that a surgical strike can be done with full force at the time and place of our choosing. Vitrectomy can be performed at any stage during the course of the disease and not necessarily within 1 week of the vitreous hemorrhage. So let's look at the evidence that we have. My opponent just pointed out studies from the archives and also the ETDRS, the DRVS, which have suggested the role of early vitrectomy in severe vitreous hemorrhage. But what we must need to understand here is that in these studies, all the patients who were subjected to vitrectomy had vitreous hemorrhage for at least 1 month. And this is what is described as persistent vitreous hemorrhage or non-clearing vitreous hemorrhage. And that evidence from 1985 still holds true because we do not have any evidence of photoreceptor or RPE damage, vitreoretinal interface damage, long-term visual loss, or increased risk of cataract or glaucoma if you have blood inside the vitreous cavity for more than 1 week. So why do we need to subject our patients to immediate surgery? What about early vitrectomy in the literature? Now, if you look at the DRS, in 1992, they defined non-clearing vitreous hemorrhage as the one that persists for more than 4 weeks. And in the recent publication in JAMA Ophthalmology by the DRCR-NET group, they actually compared use of intravitreal ranibizumab and saline for vitreous hemorrhage due to PDR. And in the study results, we actually find here that there is only a 12% probability of vitrectomy at 16 weeks after ranibizumab injection in both type 1 and type 2 diabetic patients. So what is the role of anti-VEGF in hemorrhage due to PDR? Now, there's a recent very nice paper here published in Retina 2018 in June, and this is a prospective study which has a significant number of patients here, 71, and about 64 controls, where they have looked at patients with proliferative retinopathy with persistent vitreous hemorrhage. The significant difference in the PPV rate was observed here, and patients who had mild to moderate vitreous hemorrhage, they actually did better with intravitreal ranibizumab, and they presented with better visual acuity measurements at the final follow-up visit compared to those who did not undergo. So intravitreal ranibizumab injections definitely should be considered in patients with proliferative disease, in patients who present with mild or moderate vitreous hemorrhage. Now, as far as severe hemorrhage, this same paper also did not show any significant differences with vitrectomy or ranibizumab. That's another important consideration. So the crux here is that surgical intervention at this time, the evidence suggests that vitrectomy is indicated only if the hemorrhage is more than 3 to 4 weeks old, despite advances in your instrumentation, or if there is a recurrent vitreous hemorrhage, then you would like to operate. Of course, we are not talking about vitreous hemorrhage due to secondary pathologies such as a taut hyaloid membrane or fibrovascular proliferation. We are sticking to vitreous hemorrhage, and that's my argument. Thank you very much.
Thank you very much. So you've heard Dr. KanikaAgarwal make the points that the earlier studies, the DRVS, et cetera, suggested that early vitrectomy was actually giving you your best chance at increased visual acuity, and mentioned that those were 3 decades old study, but the newer advances in vitreoretinal surgery, including small gauge surgery, would favor the safety of these newer approaches, and in addition made a cost argument that using early vitrectomy can be as cheap or cheaper than other methods such as AntiVEGF or panretinal laser photocoagulation. It has the added benefit that it may help diabetic macular edema as well, and showed several scenarios in which early vitrectomy might be useful. On the other hand, KanikaAgarwal said that you don't have to do a vitrectomy early on. You have the luxury of some time and may be able to do it at any time during the process, and that in fact the earlier studies didn't really address the issue because they were looking at hemorrhages that were more than 4 weeks old, not 1 week old, and that anti-VEGF therapy may be effective for the mild to moderate cases and really didn't have much difference when compared to vitrectomy for the more severe vitreous hemorrhages. And so with that in mind, and keeping in mind also that your vote may result in matrimonial discord, you vote yes for early vitrectomy for KanikaAgarwal, and you vote no against early vitrectomy for KanikaAgarwal. So A is for early vitrectomy, B is against early vitrectomy. So take it to a vote. Press your pads. Uh-oh. I'm not going to be witness to what goes on at home tonight. All right, well, thank you very much. That concludes our session, and everybody have safe trips home.